Hello and welcome to the next in the AISA webinar series. My name is Graham Watts. I am Director of Professional Learning here at AISA, and I will be the host or the interviewer over the next hour as we explore aspects of care for children and young people in schools. Please take a moment to introduce yourself by typing your welcome, your introduction, and your role in your school into the text box, into the chat feature. We're interested to know whether you're a counsellor, whether you're a teacher, whether you're a school leader, as that will help our panelists shape what they are saying and choose examples that are relevant to today's participants. So before we go any further, I would like our two panelists to introduce themselves. So I'm going to hand over to James. Could you tell us a little bit about your background and what you're working on at the moment?
Sure. My name is James Rosso. I'm a clinical psychologist. I'm originally from New York. I live in Madrid, Spain, and I've lived here for about more than 6 years now. My current work, in addition to having a practice here, I'm pointing here because I'm in my office, is that I work with Sean Truman at the Truman Group. We provide outpatient psychotherapy to expats and people who live all over the world, often people without sort of great access to mental health care. Just a couple more words of why I feel like I was invited here. I do a lot of work clinically. I do a lot of work with kids. I've always worked with kids. Before I went to graduate school in psychology, I taught kids carpentry and I ran outdoor education programs with teenagers. So my work has always been with kids of that age. I've worked in a couple of schools, I've worked in a couple of hospitals, I've had a private practice, and recently we've been working with AISA quite a bit. We ran a 2-day workshop last year, which Channelle will talk about a little bit, and we run consult groups for school counselors in Africa and in other places to have them have support, talk about clinical things, talk about cases. It's been really fun and really exciting. That's about me.
Sure. I think, James, you and the Truman Group have been working in some of our member schools over the last few years.
Yes, we have. Yep.
Okay, and Channelle, you'll be a familiar face to many. Perhaps you could just give us an introduction and just give us an update on what you're working on at the moment.
Sure. So thanks, Graham. So it's great to see some of the people that are saying hello, that I know your name. So I'm Channelle. I'm the Communications and the Child Protection and Wellbeing Program Coordinator for AISA. So for the last couple of years, I've been working in AISA, particularly in the child protection and wellbeing space, which is really exciting for me. My background before I joined AISA was working in sort of the aid and development sector, more in the child protection space. So since coming to AISA a couple of years ago, actually in 2017, we ran our first 1-day counsellors workshop, and we invited Sean Truman over for that. And I think for the first time, got a lot of our school counsellors in the room and really heard from them about the challenges that they were facing in their schools, both for themselves personally, as they were dealing with a lot of students that they were seeing, rising levels of mental health issues with, and feeling they, I think school counsellors work in very unique roles in a school. They're, often the only mental health trained person in a school. And so they carry a really large burden in caring for students and teachers in that school community. So AISA, as James was just talking about, AISA set up the first consult groups to really help deliver effective professional development and clinical support to our counsellors, which I know has been incredibly effective, and we've been able to expand that program this year, which is really exciting. So yeah,
and I know Channelle, when we get to the top of the hour, you'll be telling us a little bit more about the professional learning experiences planned for our counsellors. Just to give you an update, everyone, we currently have 20 participants taking part. We've got lots of school counsellors, introducing themselves. And just a message to all of our participants this evening. If you have questions that you would like me to forward to our panelists, please post those in the Zoom webinar chat feature, and I will do my best to pick those questions up and relay them to our panelists. Channelle.
Hi, yeah, so back to me. So James, I know that like globally we're seeing mental health certainly increasing, and we know that global statistics, I think for adolescents, children and adolescents are about 1 in 5 that is estimated in terms of numbers of people struggling with a mental health issue. In your experience, in what you see in your practice, in your dealings all around the world, what's your impression of what's going on?
I mean, I have strong impressions or strong feelings about what's going on, and feel that we're seeing, and I'm sure that people in the participants would agree with me, we're seeing real upticks all over the place in anxiety, depression, talk about trauma, sleep problems specifically, technological problems, and suicidal ideation and attempts. So we're seeing a tremendous uptick in that. Just to offer you a couple of statistics, and these are mostly United States specific, but I think they're applicable. Medical claims for mental health, according to insurance companies, have gone up 63% in the last few years. That's tremendous. These are for adolescents. Suicide ideation, which means thinking about killing yourself, and attempts have doubled for 15 to 17-year-olds between the years of 2008 and 2015. That's tremendous.
Doubled.
Yep, doubled. We're seeing huge increases in medication, the taking of medications, antidepressants, benzodiazepines for anxiety, stimulants for ADD. We're seeing up to 30% or more of students in schools are lining up for their medications at lunchtime. That's tremendous. We're also seeing in universities a tremendous uptick in the amount of clinicians that are being hired and how they're being utilized. So for example, a small university, Swarthmore, a few years ago, they have 1,600 students on their campus. A few years ago, they had 11 clinicians, which is a lot for 1,600 kids. This year, they have 17 clinicians. University of Pennsylvania has 58 clinicians full-time for their students. That is tremendous. The only other thing that I'm going to say is that one of the things that used to be a real predictor of mental health problems were socioeconomic status. So that the lower the socioeconomic status, oftentimes the higher the degree of mental health need. We're not seeing that anymore. It's across socioeconomic statuses, I don't know if that's the word. We're seeing it all over the place. So what used to feel like a protective factor now is almost a risk factor. So that's really something to think about. And we can contrast that. We work with schools that take in refugee populations, and we're not seeing that in the refugee populations. And they've gone through lots of issues to get there. A lot of trauma. So something is really going on. Now, we can argue whether it's real mental health need and spikes in real diagnoses, or the way that they're conceptualized, the way that they're thought about, the way that we diagnose, the way that we medicate, or probably what's accurate is some combination of both.
Yeah. Do you think too, just our growing awareness about mental health and perhaps a more openness to be talking about mental health, do you think that's...
I think that is fair, absolutely. But I think that that's a double-edged sword. Because on the one hand, it's nice that people can talk about their mental health problems and feel comfortable doing so. I see in kids in my practice, I see my daughter's friends who use really clinical language, really diagnostic clinical words to describe what we would have described a long time ago as normal experiences. So instead of being nervous or on edge or awkward, they have social anxiety, they have social problems, they've got an anxiety disorder, they use generalized anxiety terms, they use depression as opposed to dealing with some things. So I think that yes, we are absolutely facilitating good conversations and people to getting access to mental health care. and thinking about themselves more critically, we're also, it feels, helping to create, fostering people who talk about themselves in really clinical language. And that's not so great, you know?
So James, what would you say are some of the causes for these increases in diagnosis of mental health issues?
Well, I think, I mean, we've touched upon one in that it feels to me, and again, I want to distinguish what's clinical from what's not. There are real clinical things going on in the world, okay? And we can stem those back or bring those back to parental differences that exist now versus what they used to be, societal differences, technological differences, things like that, which ladder up to having more real clinical problems. The pressures that the kids are under now feel bigger. What's expected of them, the levels of feedback that they get, realistic or not, are different, okay? But at the same time, it feels like issues presenting problems are getting lumped together in that a clinical problem, a real kid with depression or anxiety or who has gone through trauma, is thought of very similarly to kids who are going through normal everyday crises of being a 15-year-old and of being in school and of having some pressure, which are now thought of as clinical. You know what I'm saying?
So James, from the point of view of a counsellor, a very busy, overworked, sometimes very isolated school counsellor, how can they, and indeed teachers across the school, how can they identify the students who may need support?
Well, I think that there's a number of things that can be helpful. I think being able to be more aware, and I'm sort of talking about each of them without a hierarchy, being able to be more aware of what the kids struggle with what society puts on them, with the pressures that they face, how parenting is different now, how expectations are different now, sort of understanding the touch points and what is going on societally is always helpful. I think being able to think theoretically and to be able to have theory that guides us in the way that we think about people and conceptualize problems. Where do these problems come from? What underlying issues, if that's the theoretical perspective? How are our thought processes triggered, and what happens then? So being able to frame what we see theoretically and with knowledge, sort of real practical knowledge, enables us to use what I think is the most effective way to do this, which is our clinical feel. When things don't feel right to us, especially when we know a lot of theory, are thinking about things theoretically, understand the difference between clinical and non-clinical, and use our experience. When something doesn't feel good, that's my most effective sort of clinical tool. This doesn't feel right to me. Something feels off. Something feels that they're not thinking well, that they're not behaving well, that there's no rhyme or reason to it. That to me feels like that sort of catches my attention in a different way.
So where does this clinical feel come from? As a non-counselor, I'm finding that scary, because I'm thinking that's beyond my realm of skills. Is the clinical feel, that insight, is that the result of professional development and experience? Where does that insight come from?
I think it's the result of absolutely professional development and experience, being with kids a lot, knowing kids, knowing what they're like under pressure, knowing what they're like when they're doing experiential education or after a test or after a hard weekend. So some of it is that. Some of it is being in places where there is a culture of communication and support, both within the students, but I mean within the staff, so that there's lots of open communication about what we're seeing, how that makes us feel, what we imagine to be the case. Being able to check things out and be vulnerable with our peers is really helpful, okay? And some specific knowledge, and this gets back to, Graham, what you were talking about some professional development and knowledge, but being able to sort of run what I'm seeing through the filter of, I've seen this lots before, I've never seen this before, I've seen a similar thing, but this feels different to me. And then, like I said, so one of the things that's been so lovely about the AISA consult groups is that counselors, who, you're right, often are very isolated and very alone, get to check things out and get to be vulnerable and get to say things like, I don't know what I'm seeing. This feels weird to me. And having people and a community to both get support, but also get other perspectives, you know?
James, I'm just wondering, do you think it's important for our teachers to get more mental health training?
I do.
Because I think Graham, as Graham said, you know, I mean, counsellors train for years to get those theoretical frameworks, that knowledge, and I'm doing a master's myself in counselling at the moment, so I'm quite embedded in it all. But you know, I think for teachers that can be really difficult, like when they don't have those frameworks to view behaviour.
I agree, and I think that what you're speaking of is a difference between sort of theory and practice. I think that it's really helpful for teachers who don't have to and shouldn't have to go through learning how to practice, learning how to do interventions, learning what works in therapy. That's not so important. I mean, it's helpful, but it's not really what I think is called for. What is called for, though, is open communication about what we're seeing, what is a clinical, what is anxiety, what is depression, what are the adaptive qualities of this. We all have it. What's good about it, what helps us, what doesn't help us, and then how to be able to distinguish the edges of what feels clinical, like, boy, this is really a problem that needs referral, versus, hey, everybody has anxiety. These kids have anxiety. They should think about it differently. They should use different attributions, and we can talk about that. And I can know that so I can push at them differently. Yeah.
And look, I think that's where it can get really challenging in schools with, you know, and hopefully teachers do have access to a good school counsellor that they can check in with and just have those open conversations with. What am I seeing here? Should I be concerned? Should I be worried?
Right. So we've worked in lots of different schools all over the world. The ones that really feel like they have a better handle on things are ones in which there's a culture, there's an ability to speak with vulnerability to each other. I'm having a hard time in class managing this. What do you think this could mean? In informal and formalized ways, to really get other people's perspectives and to start to distinguish where I can push for resilience, push for more discomfort versus where I can't.
So, so I'm seeing what from the counsellor's point of view, it's that kind of professional insight. From a teacher's point of view, though, how might a teacher identify those, you know, the two ends of the continuum? A student who may be experiencing anxiety around a specific test or a performance that's coming up, versus identifying a student who may have more severe clinical needs. What might a teacher be looking out for? I know further down the track they will take their concern to the counsellor.
Sure.
But in that early stage in the classroom, what are the I suppose, what are the indicators that teachers might be looking out for that would suggest this is a situation of gravity that I need to talk to others about?
I think that's a great question. I think some combination of the severity of the behavior. So behaviors, we in psychology define behaviors as anything, any output. It can be action, but it could also be thoughts or feelings. Okay, those are behavioral output. So we're talking about the severity of the behavioral output and the randomness or repeatability of this. So that when I've been in the classroom, a kid who acts out once, who has trouble, who's able to talk about that, wouldn't rise to the clinical level. But somebody who acts out either in really consistent ways, in bigger ways than other kids, in more severe ways, in self-harming ways, are things that would rise to our notice and to take seriously in a different way. It's all to be taken seriously, but you're asking the difference between sort of the clinical versus the non-clinical or subclinical. And I really think it's severity and if it happens repeatedly and if there's a pattern to it, you know?
Okay. So it sounds like the role of the teacher in this kind of early identification process is through observation, looking for behaviors, listening to language, and it's the severity, perhaps the repetition or the frequency of in which they're observing these types of things.
And we always look for patterns. I'm sorry to interrupt, but we always look for patterns. Sometimes patterns ladder up to making us feel sort of better about the situation. This always happens on a Monday. This always happens when a kid is asked to speak out loud in class. That's a pattern that speaks to a non-clinical thing. It speaks to either something going on at home, which should be dealt with, or specific issues around speaking out in public. Those are things that kids need to deal with, okay? In that case, if it feels random, if it feels extreme without much of a precipitant, then it's coming from internal stuff, and that's more clinical.
Those are some useful markers for teachers, I think.
What I'm hearing though too is that whether you're a teacher or you're a counsellor, you need to be really trusting your intuition and like really tuning into listening, yeah, there's a lot of being curious, asking the question, I wonder why that kid's that behaving, I wonder why, or, you know.
It's so funny you say the word curious, because we gave a talk recently about what it means to take a clinical stance. And psychology, doing clinical work is all about being curious. We're not there to judge. We're not there to determine if it's right or wrong. I mean, some things are objectively more right and wrong than others, but our job is to figure things out, and taking a clinical stance is just being curious. Why is this happening? Why is it happening today? What's going on differently? Either what's going on differently in the class, what's going on differently in the kids' lives, anything. So being curious, it feels, is a great first step, and one to sort of have in our minds.
Yeah, which is challenging, I think, too, for teachers and even counsellors who are, you know, having very busy days and, you know, sort of constantly on the move. I'm also wondering too what your thoughts are just about the role of a school counsellor, because just in listening to what you're saying, you know, we are, I think, increasingly expecting our counsellors and hoping that our counsellors do have quite a deep clinical knowledge, that they can have insight and make, I guess, some judgment calls about some of our students that we can't expect teachers to make. But I'm wondering too, though, you know, my impression of schools that are perhaps in different places in that whereas school counsellors perhaps traditionally were more providing academic advice, college counselling advice, maybe doing some social emotional classes, were you know, dealing with parents or behavioural issues. But I feel like we're really asking them also now to step into this much more clinical role in some respects, particularly in an international school where there may be less access to clinical services in that country.
Oh, absolutely.
Is that, I wonder if you've got any thoughts on that.
I mean, I do. I think that my first thought is that being a clinician these days, being a school counselor, is a very difficult job. And it used to be more defined, and it used to be a little bit more circumscribed, where now it's not. So I think you're 100% right, that it feels like a very difficult, very isolated job in which you're called on to do lots and lots of things. Some of them are in your job description and some of them are not. That is coupled with the fact that there is so much real, more legitimate clinical need, so that they are really forced to be clinicians in the way you describe that. And I think that's why it feels so important and so useful to have the workshops that we had and the consult groups that we had, because that's the kind of environment both that we want to provide for in the schools, to provide a sense of vulnerability and a sense of comfort, but it's also really skill building to know, to have lots of experience. So we've talked about cases each week. The more cases you have, the more cases you talk about, the more you just know stuff, you know? So I agree.
Can I feed through some questions from our participants? Katia is asking, building onto what Channelle said, do you think we need to build more trauma-informed care as well? Many schools do not seem to be prepared to handle children with mental health or trauma. What are your thoughts on that, James? Is that a focus for the future?
I think trauma is a very big topic in the world these days. I come at it from two perspectives. One, absolutely, I forget the name of the woman who asked the question, but one from her perspective, which is we need to be as prepared as we can for trauma, because kids talk about it more freely. It is much more of an open topic of conversation, and kids do come to us with lots of trauma. Okay, so it feels important to be able to have plans in place and systems in place to deal with that. Okay. On the other hand, it feels to me, and I talked a little bit about this before, where kids use really clinicalized language. Sometimes trauma isn't trauma. Sometimes trauma is a bad thing that might have happened, but it gets lumped in with trauma so much so that I feel like one of the things that we preach, and I think is really important, is to be able to change the way that we talk about mental illness or mental problems so that we give kids a subset of them who are lumping themselves in with the more clinically in need group, more of a chance to be resilient, to deal with things, to be able to tolerate feelings, to be able to tolerate experiences, and to pull themselves up and to like I say, deal with stuff. So I think while we do need more trauma care and do need more focus on that, we also need a common understanding that one of the things we can do is help them to think differently about their experience and make different kinds of attributions about what they can handle and how to handle things.
So it sounds like we need to explore with everyone in our schools what we mean by trauma, because it sounds like that is a phraseology that's being used perhaps in a context that it shouldn't be. So it seems there needs to be a deeper appreciation of the threshold between, as you said, some of the anxieties and pressures and stressors that we all experience, and what takes us over the over a threshold towards what we might classify as trauma.
Right. So for example, one of the things, I totally agree with you, but one of the things that we talked about last year, which we've even fleshed out more, is that what kids are particularly poor at these days is tolerating uncomfortable feelings. They're just not good at it. Okay. And they tend to crumble behind feelings, don't feel resilient, and speak about them and act about them like they are real clinical need. Some subsets of them are clinical need, or is clinical need, but some subset isn't. And helping kids to be able to tolerate feelings, to be able to deal with failure, to receive feedback, to be upset, to be angry, to be sad. Our kids are not good at that these days in the way that they used to sort of needed to be. They spent more time alone. They spent more time without technology. They allowed their minds to expand and to play and to think about stuff. If you were sad, you were sad and you had to deal with that. Now, there are drawbacks to that, but there are benefits to that too. And it feels like our pendulum has swung a little bit to this experience where our kids we expect so much from them and we think they can handle so little at the same time. So they have to be super successful, but they're very fragile. That's not so helpful. That's a troubling attributional style that we are feeding them.
It's interesting. And that ties in with your earlier point, Channelle, about the role of the counsellor in the international school becoming much more complex.
Sure.
Yeah.
We have another question coming from Susan at Brookhouse in Nairobi. Susan says, how do you differentiate between attention-seeking and real suicidal ideation?
Great question.
Or refer. So, much praise from Channelle. Thoughts in response to Susan's question?
Me or you, Channelle?
James.
Okay.
You can answer that one, James.
It's a tough question. It's a good question. Clinically, in a psychologist's office, we would go back to things that we know about the diagnosis of the kid. So somebody with a personality disorder, a borderline personality, for example, we would run it through the filter of thinking that they were being attention-seeking, because oftentimes borderline people, and we see it in kids too, feel that they're not going to get paid attention to unless something's really serious. Okay. So oftentimes they ramp up the way that they talk about themselves and what they feel like they might do to get attention. Whereas somebody who has a real mood disorder, who's depressed and struggling with grief or trauma, they wouldn't be looking for that same kind of an attention-seeking way of talking about suicide. So some of it is clinical experience and diagnosis. In the classroom, though, it feels like if some kid is talking about killing himself and we don't know whether that kid has a long history of saying this, what diagnosis the kid has, what kind of treatment the kid has, it feels like we need to err on the side of being really careful and treating it all like it's a big deal. But clinically, there have certainly been times I've said to kids, you know, you don't have to be suicidal. I can pay attention to you without that. And that's soothing. But that requires me to know what they're dealing with, to know them, to have a relationship.
Sure.
It sounds like, just to summarize, James, there, in that sort of situation, a school would always like think of developing a safety plan or something, like just to make sure, even if the kid is attention seeking, that your behavior to them is showing I'm listening, I'm caring, I'm paying attention. Like whether it's attention seeking or it is actually.
So I would want to have a safety plan, but then I'd also want to be able to circle back around and try to influence the culture of the school to incorporate some of this knowledge. So one doesn't have to be suicidal to get our attention. There are plenty of different ways to do that, even though we are going to take it really seriously in this instance, you know?
Yeah, for sure. For sure. And hopefully counsellors have a little bit of training on how they can ask kids those questions around, you know, are they suicidal? What are they thinking about? You know, because there are formats to do that.
Sure, there are formats to do that. I've worked with counselors who have felt the need to be given permission to ask these kind of questions. But I agree with you. People should be able to ask directly. Do you have a plan? What is the plan? How do you have the means to execute the plan? Those are questions.
And it's okay to ask those questions. In fact, we should. Just to be clear to anyone who might be listening to this later.
Just a couple of other comments coming through from our participants. Dee at ISK, Nairobi, made a comment when you were talking about, when you were both talking about the role of the school counsellor, saying how that role has stretched and grown and deepened, and how that can at times be challenging in terms of ethical boundaries for the school counsellor. And Peter in Cape Town made the link between what you were talking about in terms of trauma and vicarious trauma for those who are around trauma, but perhaps not directly linked themselves. Did either of you want to comment about vicarious trauma?
I mean, vicarious trauma is a knotty issue. It is a real thing. I mean, as much as we can start to differentiate what is really trauma versus really not, vicarious trauma can be real trauma. Seeing somebody go through something can have the same impact on us and can ladder up to real symptoms of PTSD, even if the thing didn't happen to us. Even hearing about a traumatic experience can do that with more vulnerable kids. So I think that's
and can I add, teachers and counsellors too. If you're in a role where you're, often supporting people who have been through traumatic experience and you're in that caring role, that can, also put you at risk of vicarious trauma as well, I think.
Sure.
So in some ways, this is, my next question is going to take you almost back to the beginning, but what can schools do in terms of prevention? What can schools do to build coping skills, to build resilience amongst students?
I mean, I appreciate what you're saying. It feels, and I don't mean to be repetitive, but it feels like it's what is going to arm schools and steel us and help us to be as prepared as possible are some of the same things that I'm talking about. Being as knowledgeable about the kids, being as knowledgeable about the world and what's going on, why the kids are having such trouble, the concept, being able to have a school in which we talk openly about the concept of being able to differentiate the clinical from the non-clinical. Because I think one of the things that is very hot and important in schools is being able to teach resilience. Resilience, in my mind, in this context, is being able to tolerate feelings and tolerate stuff. okay? So we want to develop a culture, we want to develop environments in which things are talked about openly, in which people feel comfortable, people can feel vulnerable, people can feel appropriately boundaried, but can talk about things, give and receive feedback and feel supported. It is in those kind of environments that resilience can grow, and some of the subclinical can stop appearing at our offices, okay? That said, those kinds of process groups, those kinds of being able to talk to one another also enable us to be really effective, to have common language, to have common types of interventions, so the kids get the same messages on different hallways and from different people. And where we can, like we've said before, if I'm a math teacher and I see a problem, I can go to the clinician or to anybody and say, this is what I'm seeing. Let's figure out what's going on and figure out a plan. So it feels comprehensive and granular at the same time. We want everyone to be talking the same language. We want everyone to be thinking about building resilience. I feel like the way to do that psychologically or with clinicians is through communication, through being able to tolerate feelings, being able to differentiate feelings, sort of building self-awareness. And if you think about that as the model, the more self-aware that the organization can be, the more that ladders up to helping kids to be more self-aware.
So it sounds like, James, you're talking really about a whole school culture.
I am talking about school culture. Because it is in the whole school that this stuff gets manifested and manifested in difficult ways. So yes, I'm talking about a whole school culture of knowledge, understanding, common language, common vocabulary. It would be great if everybody knows, from the PE teacher to the lunch line, everybody, what attributions are, what anxiety is, what's good about that, how to help kids, how to talk to kids about it. And sometimes the best intervention is, yeah, that's a bad feeling.
Yeah.
Really.
Yeah, so, and even normalize it a little bit more. I think maybe in our culture where we're so maybe a little over fixated on being happy and, you know, all those like pleasurable emotions that we all want to feel.
I agree. And that's one of the things that and I'm a parent and a today's parent, so I feel the pulls in the same way. But I feel like one of the mistakes that we as a culture of the big C part make with our kids is that we need them to be happy all the time.
Yeah.
That's not really a great way to be, because first of all, it's unrealistic. And second of all, it doesn't help kids to be able to sit with unhappiness and understand that and soothe themselves, which if you think about, if they don't do that for a long time, and happiness, if you're not happy, that's a real problem, and you don't have the coping mechanisms to make yourself happy and to soothe yourself, what then comes when bigger issues start to arise? That's what and like I said, I'm really trying to be sensitive to the fact that there are real clinical needs and kids with real problems that we deal with. But a subset of them need to be handled differently so that it doesn't ladder up to the same kind of clinical need. Does that make sense?
So
it sounds like it sounds like some of what we're talking about really is whole school cultural change. And as we know, that is a challenge, particularly in a situation where you have such a lot of churn, where your staff are turning over and your students may be turning over. Trying to change culture and then sustain a cultural change can be a challenge. But it sounds like the focus is shifting from intervention to prevention. Whereas intervention is by necessity, intervention can only cope with a certain number of students. The prevention approach is working with every student, and indeed a lot of what you've just said is just as relevant for the adults working in the schools, being resilient to the challenges that they face, and to the wider educational profession generally. You know, we spend a lot of money recruiting teachers. I don't think we invest enough time and resources in retaining teachers and helping them to develop a resilience and be able to be survivors and make a success of some of the challenges that they may face in the international school sector. Channelle, did you want to add anything?
No, sorry. I was distracted reading the comments, actually. Sorry.
Okay. So, James, moving forward, I mean, thinking about the work that you do in schools, are there um, you know,
Well, what do
when
schools
kids,
do for that for the group of students who are really struggling?
what are some of the effective strategies?
Yeah,
Well, I mean, for the kids that are really clinically in need.
yeah,
Okay.
yeah,
A combination of making appropriate referrals, because
yeah,
what we're talking about is not really stuff that school counselors should have to deal with. And
yeah.
it really isn't appropriate for the school setting. So that I think one of the things that's really important is to be able, and why we do this is to be able to distinguish clinical from non-clinical, so that we can make appropriate referrals and also have a way to then conceptualize that in the school. So talking about a school culture, it's like, we're making this referral, here's why we're doing it, here's going to be what success is going to look like, here's how we want to reintegrate the kid back into the classroom with these provisos, and everyone's on the same page. So making an appropriate referral, having good communication around what's happening and around how to sort of reintegrate and deal with whatever the school can be helpful with.
Yeah, yeah.
We have a question from one of our panelists, from Peter, who is the AISA Executive Director, currently in Cape Town. Peter asks, how do you persuade teachers who are not trained in the area of wellbeing to become more actively involved or curious, in your term, about their students' well-being? In other words, how do you get over this, this "it's not my job" phenomenon?
Okay. I can give you an anecdote about that. We recently did a seminar in a school in India, okay, in which there were many other people besides the clinicians were there, the counselors were there, but administrators were there and teachers were there, and we certainly had some of that. Sort of like, what am I doing here? I'm a math teacher. That's not my thing, okay? We ran for them a 2-day seminar in which they got a lot of the benefits in the same way that we would be doing for the kids. They talked a lot about themselves. They talked openly with each other. They talked about their own touch points. They gave and received feedback. We then broadened that and talked about how this is a model for resilience, for being more self-aware, the benefits of self-awareness. So we sort of gave them the experience, and then they were able to relate it to how they could be better at work, and it felt more personal to them. So by the second day, the group felt much more cohesive, but people learned some things about themselves and about each other, and they felt more like a team. And they then could see in live time what was beneficial about this. So it felt like we got a room full of converts who said, I want to be able to do this with my students because this is so helpful. This was helpful to me, and I'm 35 and I'm not struggling, you know? Think how great this would be for the kids. And it felt like we got converts that way. You know, by showing them the benefits and by modeling for them what we want for our kids.
So for helping those teachers to experience themselves.
Right. It is truly experiential
some of those
learning.
tools, some of those,
Some of the benefits of those tools. Now, they don't have to learn the tools, but they need to know the benefits of it so that they can be on board and understand why resilience is good and why it's good not to, when I'm sitting in the car and I have a spike of bad feeling, not to just text it away, but to sit with it and to learn from it, you know?
So James, if I can just extend that, that point a little further, if schools are thinking about where to start in terms of developing well-being, would you, I've seen some schools start with a focus on the students' well-being. Some schools start with a focus on the teachers, the adult community working at the school. Some schools start focusing on both and possibly even mix in well-being of parents at the same time. Is there a difference? So what would you recommend in terms of the efficacy of those starting points?
I mean, I've done some of all of that and have had a long history of this. So it feels like my thinking has evolved over time. So when I used to work in experiential education, we did all the training of the staff first before the kids ever got there. That was my original feeling, and it still sort of holds true to an extent, although it feels like the most effective environments are one in which we're all doing similar things. So that training for the staff in this area feels exactly what community meeting for the kids is going to feel like and seem like. So it feels, to your point, that we wanted all of those things, but I do think it's really important to start with the staff and start with the most inner of the concentric circles and work our way outwards. So I think it's most effective to start with heads of school and administrators and then move out to the teachers and the staff and all that stuff. literally sort of helping each circle to be able to have that mutual influence, that bidirectional influence between shaping the culture in the big C and shaping the individual cultures that each kid sort of brings.
And that would certainly support your earlier suggestion that a focus on well-being is about whole school change. If we want to achieve sustained whole school change, then we need the heads of schools on board. We need them modelling and practicing and promoting these ideas rather than it being left to the counsellor or to a certain group of the faculty.
I really think that is true. And I've seen it work well. I've also seen it work badly, but I've seen it work really well. And it's where everyone is talking the same language and they really feel there's a real sort of sensate shift in the way that people are interacting with each other. And it is pressury in that it is not the easiest, but I really think it ladders up nicely to being able to know what the kids are struggling with, to be able to identify with it, and be able to then provide for them the environment that is gonna differentiate clinical from non-clinical and gonna be increasing resilience.
And just on that point, for school leaders who may be tuning in this evening, or perhaps for those of you who are going to go back and talk to your school leaders, we do have some professional learning opportunities on wellbeing coming up at the AISA conference in Cape Town in 3 weeks' time. There are some deep dives focusing on the role of the leader in developing a whole school focus of wellness. And just another question coming through. In the AISA context, what does that mean for a counsellor in, let's say, Mali, where referrals are difficult due to language, accessibility, cultural variances for school counsellors to seek out the resources that they need when making referrals? That's from Peter. I think that's going back to your...
Can I answer that so that James doesn't have to? I would say call the Truman Group.
Okay, good.
So I don't want to put you on the spot, James, but I mean, I think that's where our partnership with the Truman Group has been effective, and I know that some of our AISA schools do refer out to the Truman Group. I think I mean, we're on an online platform now, and I think it can be just as effective to get some counselling support even via an online platform. It maybe isn't as ideal as face-to-face, but if that's the situation you find yourself in, I would seek out a...
The more I do this, the more it feels the same to me. I have to tell you. I think it is. There's something a little better at being in the room. I agree, but it feels the same to me. It feels...
Particularly when I can see you, I can look into your eyes, and like there's still that connection. I think I can hear your voice. I can hear the tone of your voice. I can still see your body language. I can still see how you're holding your body, how you're responding. So, look, I totally agree. I think it's incredibly effective still. So
one of the nice things about the Truman Group, and I work for the Truman Group, but I really objectively think this, is how quickly we respond. So that people who make referrals to us can literally be seen the next day. We have a big intake staff, which is incredible. You can't get that in the United States.
Even in Brisbane, you can't get that sometimes.
So it does feel like the cavalry's there a little bit. I like to be a part of that. It feels very rewarding to be able to step in and be helpful in that way.
And for counsellors who may be interested in learning more about the Truman Group, I'm sure they can reach out to you, Channelle, and learn more. We are... nice feedback here from Ashley. I agree. The Truman Group is amazing and has been a very useful tool. So there we go.
Thanks, Ashley.
We are heading towards the top of the hour. So one of the questions earlier was... well, I am. So I'm
You've been listening to the BBC.
This is London calling. So one of the questions earlier was about recommendations for professional learning and professional development opportunities for those who are working in this space. So perhaps, Channelle, could you speak to some of the upcoming professional learning opportunities for counsellors in the AISA region?
Yeah, definitely. Look, as you mentioned, there's heaps of opportunities at the AISA conference in Cape Town. We do have a number of different sessions that are not specifically for counsellors, but are certainly in the well-being space. We have someone talking about neuroscience. So there's lots of things at the AISA conference, but the most, I think, effective or best training will be the counsellors PLI that will be in Tanzania in February. So James came and led that last year. It was a really fantastic couple of days. I think there's something really special about having a group of counsellors able to come together. We speak the same language, very much dealing with similar issues, similar challenges. I think it was an incredibly supportive group and a safe space for people to come and just feel like people in the room get what they're going through to some extent. They understand those challenges, and so could come and get some experience some really great training. Some of those things that you talked about, James, about what it is to be in a process group, and really develop those skills around thinking clinically about a case. You know, how do I formulate how I should think about these students I'm seeing? Mm-hmm. One of the things that we will do in every counsellor's retreat is make sure we have dedicated time for some consult groups, and we'll be doing that again so that counsellors can come along and really discuss some of the critical cases that they're seeing, and just sort of, and I think it's so useful to run that through a sort of filter of other counsellors, like, you know, what are you thinking about this? What you know, is there another lens I can be looking at this through, and things like that. So look, there are lots of reasons to come along to that weekend, and it will be fun. And it will be fun.
Excellent.
Yeah.
There's just one final question that has come through. So James, I'll aim this at you.
Great.
What are your thoughts on using mindfulness and meditation with students who are experiencing distress?
I think it's really helpful. I think it is absolutely consistent with what I'm talking about, because being mindful, using meditation, and either guided or not, and I do it myself, and I want my patients to do it. It enables us to be more self-aware. And it also enables us to have a different relationship to our feelings a little bit, so that our feelings can come in and we can observe them and not react to them and watch them go. It's sort of a nice model and a nice training ground for what we're asking the kids to do, which is, I have some sadness. I have failed something. I am bored. I am unhappy. How can I deal with that versus what I'm pulled to do, which is act out behind that, or think about it in big terms, or look to get terrible attention, or do something. It feels like being mindful is exactly the skill we want. And meditation is one of the ways to be mindful and to be intentional around having a different relationship to how I react to my feelings. So
can I just add on to that? I totally agree with everything James just said. And for all those reasons that James just talked about, my advice or whatever is to be doing that before kids get to that I'm really distressed. Okay, now mindfulness is the answer. Like, this is like, I always think of it's a skill, it's a muscle that we want to build, so that, like, I think it's really difficult to go into that space when you are really distressed, when you are really anxious. But if we can be developing those skills in kids, and it's building, you know, a resiliency tool, I guess, that they have in their toolbox then when they are in those spaces where they're finding themselves really angry or depressed or whatever it is, they've got those tools to go to, if you like.
It's a prevention strategy rather than...
Yeah, I think it's really hard when you're in the moment to be like, okay, now try meditating. Like, I mean, it might work, but you know, yeah.
Sure.
No, I agree with you. It is definitely a skill, but it's a really important one, and is exactly consistent with everything we talked about today.
Yeah. So definitely, I think all schools should be doing it. I think this too goes back to your experience. Like if you can get teachers experiencing the benefits of a mindfulness practice or meditation practice, whatever you want to call it, you know, that then helps motivate them, if you like, to be doing that in their classrooms.
Sure,
and it, yeah.
And just plugging our our educator wellbeing sessions at the AISA conference in a few weeks' time. We do have some mindfulness workshops for the participants to join in. It's not a how-to, but it's a mindfulness practice for the
Come and
participants.
experience it. Yeah.
Yeah, absolutely.
Great.
Okay, well, we have run out of time for today. We've answered our questions and we're getting some great feedback from our participants. So I'd like to thank James and Channelle for their time here this evening. Today's broadcast is being recorded. It will be posted on the AISA website in the next week or so. So you can access it again, or you can link it to share it with others in your school. Channelle and I will be back to talk more specifically about well-being strategies, programs, curricula for children and young people in schools in January of next year. So thank you, James and Channelle.
Thanks, James.
Thank you very much. I look forward to meeting
Thank
you all in
everyone
person
for joining.
Thank you for joining us. Bye-bye for now.
Bye-bye.
Bye.